Thank you very much. I think Jennifer has certainly framed the challenges that still exist, that we have a long ways to go before children can be cured of this disease, and the devastation that you shared with us is deeply meaningful. And Eric, your story is certainly one that we both celebrate and acknowledge in terms of both impact that this has had on you and your family. It was notable during your presentation that you almost always use the word we when you were describing the journey, which I think really speaks to the fact that this is truly a family event of extraordinary proportions. And I think the twists that the story took are both remarkable, encouraging, but certainly had an illustrious career and basically led, as we know, the Children's Oncology Group, and now is at the FDA. And you said it, but I want to underscore this, and I'll ask the three questions, and then we'll go back down because they're interconnected. That, certainly there are profound differences, obviously, in the basic biology of childhood cancer as compared to adult malignancies. And there are unique opportunities to understand how some of those biological insights might lead to therapeutic results. But there's a reluctance on the part of industry to develop drugs specifically for rare diseases. And I think this is one of the really important challenges that we all have. I mean, there is a notable example in cystic fibrosis that stands out where a foundation, the Cystic Fibrosis Foundation, collaborated with inventors, discoverers of a drug that's had a huge impact on a rare mutation in cystic fibrosis that's, to me, serves as an exemplar of how we proceed forward. So I'd like you to reflect a little bit on, now that you're at the FDA, how we might not begin by saying it can't be done, but rather think about how it could be done. I know we're going to have some dialogue about academic industry interactions later in the session, but let's not be from the point of view that this is hard. Let's think about how to make it happen. Now, Smita, you really shared with us the complications that we know are occurring, but I think the important element So how do we go about anticipating the complications, and to what degree do we share that anticipation with parents like Eric and Jennifer when they're beginning their journey? And then Mary Jo, you spoke about the importance of the care dynamic, but as a connection between all three of our speakers today, we certainly are going to witness many children migrating from the team-based psychosocial care that exists in pediatrics to a very different environment, which is the adult-based care model, which is highly fractured, not coordinated, doesn't have all of the components associated with it. How are we going to deal with that in developing the right group of people to care for our children as they grow older? So Greg, we'll start with you, and then we'll go back to the open discussion.
Well, thank you for the question. I wish there were a simple answer. And I do share your enthusiasm, respect for the Cystic Fibrosis Foundation. I mean, I think what they've accomplished is extraordinary. I think the difficulty, or maybe the problem in pediatric oncology is that we have existed with very significant federal support for a long period of time. never enough federal support, and currently shrinking and disappearing federal support. But in cystic fibrosis, they never really had that. So the development of a foundation to really support therapeutic research efforts and specifically drug development efforts, I think, to some degree, originated from that. I think that even though what they've accomplished is remarkable, I think one also has to look at the sort of separation of the potential income generating opportunities associated with drug development and clinical research when working in this area. I think that there are real opportunities for public and private partnerships. I would hope that industry is becoming somewhat more open. I think they are actually, and I think there are some opportunities for legislatively dealing with developing drugs for rare pediatric conditions, and not the current legislative initiatives, but I think there has to be some modification. But I think it's a model that could be emulated in pediatric oncology. But I think it needs some considerable tweaking, if you will.
Well, I think that's, thank you for that. I would just add the following. Most the big pharma industry has been moving rapidly out of the field of development, of the pipeline of discovery. And this is not just related to oncology, it's related to many drugs across the board. And so the partnership with foundations and academia becomes ever more important. And because of the rarity of childhood cancer, that's going to have a really important starting point in many of the cancer centers that deal with children. But I think that the next phase of that, and I know we'll have more dialogue about this going forward and during the session, is to not let the regulatory rules become impediments to success. I mean, in sort of my lifetime, as you know, I've watched this happen many times, and it requires being proactive to get over it. And parents could make a huge difference in helping to lead that effort. So I hope we'll find ways of accomplishing that. Yeah.
Well, I would just say that before going to the FDA, I viewed the FDA as a huge obstacle and impediment.
Right.
I think there are changes being made, and I would echo the plea for parents and advocates to get involved.
Yeah.
They do make a difference. They really make a difference in adult drug development, and I think there's enormous opportunity for families and patients.
I agree, and I ultimately had a very good relationship with the FDA, but I remember well the frustration, not in cancer, but in HIV drug development, of being very frustrated by the lack of progress. And actually, here we are in Washington, where one day, as we were developing therapies at the NCI for children with cancer, I had a call from the Washington Post about why our results weren't being translated into activity. And I said, not knowing what would happen, that the FDA was full of lunatics. And I learned two things from that. One is that appeared on the front page of the Washington Post, and I get into trouble over that. But the second was a week later. There was enlightenment at the FDA, and they moved forward. So I say that with a little tongue-in-cheek, but also because these collaborations can make a difference, and they need to be triggered by proactivity as well. So Smita, take us through.
Can I just do a follow-up?
Yeah.
One of the things that you use the Cystic Fibrosis Foundation as an example, and one of the issues that I see often is, that is one foundation and one disease. We have, I think, Rebecca, you know the number, but 3,000 organizations involved in raising money related to cancer. all with their own agendas, and that may be a really good thing because it has more ideas coming out.
Yeah.
But I think, that it really fractures our ability to really focus and get the answer. I wanted to know what you all thought about that.
I'm glad you said that. I think it's a really important commentary. And of course, we live in a world where we want to foster the spirit of entrepreneurship and of people moving forward. But there are times when, we can and maybe need to look at how to orchestrate things better in a more targeted way in order to make things happen. I think Greg stated it correctly. We're in a new era, and we need to think about more creative public-private partnerships, and that may require giving up some to gain some. Okay, so what about those complications?
Well, so Dr. Pete, so you are asking me, can we stop looking in the rearview mirror, and can we anticipate these issues up front? The easy answer would be no, we can't. That's why I admire you so much for pushing us in directions which are different. Why I say no, we can't is because of the following reasons. The new drugs that come in are unknown to us in terms of what toxicities they would cause to organ systems other than the target that they're targeting. Usually these complications have a latency. Sometimes very short, but usually very long, in the order of decades. So to anticipate these issues can be a problem. What can we do? We can do two things. One, we can be absolutely hyper-vigilant. We absolutely have a moral responsibility that whenever we're introducing a new drug, that we follow our patients long-term. We don't let them out of sight. We don't say that you're done and you are released into the world without follow-up. So that's one responsibility. But really taking up Dr. Pizzo's challenge, I think there is room for identifying a group of patients who are vulnerable to organ toxicities, irrespective of the therapeutic exposures that we are exposing them to. So maybe create a gene signature, maybe create a clinical profile, which would then place them at a higher risk, and anticipating that and following them more aggressively rather than that. So, measuring their telomere length. So maybe looking at their DNA repair profile, or maybe looking at genomic instability in some other way, or their age, or their gender, or their race, ethnicity, but somehow figuring out a profile that places them at a higher risk.
Thank you. And I think that the importance of that is particularly true in children. In adults, the reality is you're diagnosed with cancer and you're already along the life journey, with longevity being what it is today, with 30 years gained in the last century, with people living into their 80s and 90s, and children potentially becoming, quote, really long-term survivors. The likelihood of complications is only going to increase. So what about those transitions of care, which, based upon my last statement, may not only need transitions to internists and adult oncologists, but to geriatricians? How are we going to handle all of that?
I was hoping I would learn that from this conference, but I think that there are already some places that attempt to do this, where there are several different ways. One is in the long-term survivor and late effects clinics that at least many of the moderate to large size centers have now or are developing. They keep patients, or former patients, whatever you want to call former cancer patients, survivors, into their 40s or even longer. I know our site does, and there are several others. I mean, they don't have to, but many of them want to continue to come back there. However, they're then transitioning to an internist probably for their medical home instead of oncology, which was essentially their medical home for many years. So there are some long-term survivor clinics that do that. There are other, I know of a couple of other places where the long-term survivor clinic at the Children's Hospital has developed along with one at the adult hospital, and so they try to maximize the transition. Some people come over in the beginning and are there to try to help with transitioning to the adult care, and that seems to work well, I think, for a number of people. But then there's this, and one of the things I think that we need to do is really assess which kinds of models are going to work best for people, and I don't think we know that. And I think there needs to be research to do that. And again, I go back to my elephant, that's going to cost something, but we don't really know, I don't think, what is the optimal way to achieve the transition. Now, for many people, they're in their community and they don't have a large size hospital, and so there might be a community hospital, and they might be going to an adult internist. I think that's probably going to happen a lot. So what can we do there? Well, one thing might be to work through the adult internal medicine or family medicine organizations to provide some education as to what they will be doing. I know in the American Academy of Pediatrics they have some really good programs like that to educate their pediatricians all over about different chronic illnesses and also about psychosocial care. They've really made great strides, and so I think that might be one way, is to increase education for people in the adult world, and that also would be true of the people that would be part of their care in the psychosocial and related realms, because I don't know that we do that good of a job of educating our adult colleagues who may end up working with these children. But I do think development of effective educational programs would also help. But they're partial solutions.
Well, thanks. And we're going to go to questions. I just add very quickly that we ought to look, as we're doing that, at other team-based models as well, because it's not just physicians. We ought to be looking at the role of nurses, nurse practitioners, social workers, others who can really collaborate in making sure these transitions occur. So we have time now for questions. We have microphones at, I think, both sides of the room. If you can go to the microphone, that would be great, and identify who you are and what your affiliation is as you're going forward. Use the microphone because this is all being recorded.
Good morning, Jonathan Agan from Max Care Foundation and Children's Cancer Therapy Development Institute. I don't know that this is so much of a question as it is a statement with respect to one of the words that we in the community hear so often about childhood cancer. That's the use of the word rare. And statistically speaking, yes, it's rare based upon the numbers. I can't add 2 + 2, which is one of the reasons why I went to law school. But with that speaking, any disease is rare until it knocks on your door. My daughter was diagnosed with DIPG back in April of 2008. No treatment advances in 30 years of classification of disease. So, Dr. Riemann, I guess this is more towards some of the comments that you made. As a community, we need to be careful with the messaging that we send forth. If we are to incentivize industry and Congress and the community to act as a whole and get on the same page, we need to be able to market the cause better and find where we fit within the rare disease population versus just the childhood cancer population overall. So I guess my question to you is, based upon your comments about the necessity for a legislative fix to some of the incentives, where do you see this all coming together with the specific pieces of legislation, or are you talking about new legislation? Thank you.
Thank you for the question. And I agree with you 100% that rare is a relative term. And it's used really in the context of looking at cancer and the population impacted by the disease based on age. The other use of the term rare really has more of a regulatory basis, and from a rare disease program, the orphan disease program within Health and Human Services, it's a disease that affects less than 200,000 people. So rare is being used in that context. With respect to the legislative fixes, since I have to work as authorized and mandated by that legislation, I'm probably not the right person to provide comments.
That's
But
okay, why don't you go for it?
But I think there are opportunities. I mean, I think the incentives provided by the Best Pharmaceuticals for Children Act, BPCA, are significant and enormous from a financial perspective, but they come very late. And what we keep hearing all the time is that companies fear making any commitment to a pediatric development plan early that may flame out, and therefore they've invested money and then there's nothing in return. So looking for something that provides an incentive, a meaningful incentive, whatever that happens to be, earlier in the process, I think is one way to approach this. The other way that there could be a fix, if you say to use that term, would be to move some of the requirements and timelines up. That just happened a few years ago with FIDASIA and the requirement for pediatric study plans earlier in the process. It could really be moved up even earlier than the end of phase 2 considerations. So I think there are two potential fixes that could be made.
Yes, please.
I'm Richard Plotkin, also from the Max Cure Foundation. Prior to 2008, I spent my life advocating for clients in front of juries. My grandson was diagnosed in 2007. He's now a 7-year survivor. As part of the Coalition Against Childhood Cancer, Beth Ann Baber's dad, Joe, and I put together statistics that are on our website. We rejected the statistic, Dr. Riemann, that you put up on the screen, that 2,000 children die a year from cancer. The reason we rejected that is because that's the 5-year period. Children that survive the 5 years, the statistics, and I'm relying now on American Cancer Society, 35% will die within 30 years of diagnosis. That means that following the 5-year period, 18% will die in the following 25 years. The average age of a child getting cancer is 6 years old. 98%, and again, I'm relying on American Cancer Society statistics, 98% of childhood cancer survivors have long-term health side effects, ranging 1/3 of them chronic and severe, 1/3 moderate to severe, and 1/3 slight. So my question, and I'm going to have two questions. My first one, Dr. Riemann, why do you say that there's 2,000 children die each year? Because as an advocate, I look towards talking points that will gain people's awareness and understand the needs of pediatric cancer. And Joe Baber and I rejected the 2,000 number, and I wonder why you used the 2,000 number when the survivors are so subjected to death themselves.
Well, we used the 2,000 number because that's the number that is available through the surveillance epidemiology and end results program. So we're certainly aware of the fact that survivors have significant sequelae, and that some of those sequelae, as Dr. Bhatia clearly pointed out, result in early increased mortality, but it may not necessarily be due to death from cancer as much as it is death from complications of either the cancer or its treatment. So the 2,000 number are really cancer-related deaths, so because of cancer recurrence and the implications there.
The problem with that is a few years back, the head of NCI testified that with an 80% survival rate, we must be doing something right. So what I, as an advocate, look for,
Sure.
based on accurate facts, is something that will convince Congress and the FDA and just the public that pediatric cancer has great needs. And all I'm suggesting is then supplement the 2,000 number with some of these other documents. The other question I have, Dr. Riemann, is that with respect to clinical trials, it's my understanding that there's a dearth of clinical trials for children, and that it's not until the adult testing is concluded after phase 3 trials that certain drugs are then selected to be part of clinical trials for children. Why can't we accelerate that to following phase 1 trials on these promising drugs? Why can't we then get the children's clinical trials going? Because now with the compassionate use issues that our Congress is addressing and industry, I think it's going to be less and less where industry is willing to give experimental drugs to children as a result of certain of the things that have occurred this past year. Thank you.
Yeah,
Well, I just want to respond to the second, and I think not all. I mean, there are a limited number of clinical trials that can be done because of the number of patients. Again, we're talking about a relatively small population of patients, and hence the rare disease nomenclature, if you will. It does work against us. As far as the timing of initiation of early phase clinical trials, they don't have to wait until drugs are approved in adults, and they're not waiting. So there are a number of early phase clinical trials that are done in children before a drug is approved. And the agency is of the feeling that if the science supports it, early phase clinical trials of specific drugs could be done in children without any prior adult experience, depending on the drug and depending on the indication.
Great. Very important. Thank you. Otis?
Yeah, Otis Brawley, American Cancer Society. Going backwards, one of the great problems that we've had in adult oncology is less than 3% of adults go on the clinical trials. It's actually 60 to 70% of kids up to age 12 that are currently going on the clinical trials. That's a very good thing. Now, for teenagers, we do have a paucity of teenagers with cancer going on the clinical trials. In terms of the statistics, Dr. Riemann's 2,000 is correct. I'm from the American Cancer Society. We publish the numbers. One of the issues that you come into in developing those numbers is they all come from death certificates. If you have someone who's 35 years old who dies of a congestive heart failure that was due to adriamycin, if that death certificate has written on it by the doctor who signed it that the patient had congestive heart failure secondary to treatment for a cancer, then that person will be coded as a cancer death. However, if the person was cured of their cancer 20 to 30 years ago, the likelihood that the doctor who's signing that death certificate, who might very well be a resident who's taking care of people in a hospital or an attending physician in an emergency room who doesn't know the long history of the patient, the likelihood that the fact that that person had cancer will get onto that death certificate starts diminishing. So it really becomes, you cannot really get an accurate number of how many people die years after they have been cured of their cancer, die of the cancer cure. The best number that we have is how many people die per year from cancer, and that's the 2,000 that Dr. Raymond mentioned.
You know, thank you for that point. And of course, it's important to also underscore that that is not unique to cancer. Death certificates are often irrelevant in terms of what's really happened because they dismiss the underlying disease. And I think what you're speaking to, and Smina, you were speaking to as well, is the need to have interoperable data sources that will follow people over time. And once we eventually have electronic medical records that are truly interoperable, that will be a way of overcoming some of this. Do you want to?
Yeah, I just wanted to comment, if we could follow the Scandinavian model and link all of our registries, we'd have a much better sense of what was going on.
So we'll have one last question, comment.
So to follow up on that, what strikes me is that you need long-term. My name is Lee Granberger. I'm with the Leukemia Lymphoma Society. You've got long-term follow-up issues. You've got relatively rare diseases, and that's on one hand. On the other hand, you have electronic medical records. You've got genomic sequencing that's fairly sophisticated now, and it seems to me you have an opportunity for a national registry, for somebody to actually put it together and take all this data from patients who might start in New York and wind up in Washington or out in Idaho, and put that information together. And it's that type of information with the Scandinavian, Norwegian country models that we would need. And so that's what I posed to the panel. You need a national registry.
Yeah.
Actually, can I respond to
Sure,
that, Dr.
please, go
Pizzo?
ahead, yeah.
Within the Children's Oncology Group, Dr. Adamson has initiated a process called Project Every Child, and that is enrolling every child with cancer and developing a registry along with biospecimens, clinically annotated with therapeutic exposures. And we're linking that with long-term follow-up of those patients for life, and that is exactly what is happening. So, yes.
Okay. Just a very short question.
Good morning. I'm Peter Brown with the Maddie Miracle Cancer Foundation, and I'm going to end my question asking for a piece of advice or guidance from you guys. While this is not a question about drug development, we strongly feel and believe that it's more than just about the medicine. And so I want to key into something that Dr. Bhatia had up on her presentation, where they were looking at the long-term cancer survivorship guidelines, and they had that multi-year educational program to try to educate about risks. And what was pointing on that is that there was nothing about mental health or psychosocial issues. There was neurocognitive, but that is not the same. And so my advice to you is, how do we get that as yet another risk factor that needs to be tracked, not just for survivorship, but all over, but in particular for the survivorship guidelines? How do we get that added as a critical and essential risk factor to track?
So actually, I'm sorry, I was remiss in including that as a particular outcome that we did measure. We did measure it. The survivorship guidelines do have a very exhaustive section on psychosocial issues and how to monitor them and how to surveil for them and provide the necessary expertise in terms of taking care of patients with those needs. So yes, they are there. Now, chronic fatigue is something that is, unless we follow patients longitudinally, we are not going to pick up on those kinds of issues unless we've anticipated.
Yeah, just to follow up in terms of this issue for our, hopefully, things that will come out of this, is one of the problems with the psychosocial care of these patients is it's not reimbursed in many instances and places. And so, for example, in the state of Florida, Medicaid, which constitutes 50% of our patients, psychosocial care or psychology services are not reimbursed at all. And so that's something that I think we could impact on making a change on a national level.
Great. Well, thank you very much. I think the panel is commended for raising many issues and topics, much of which can continue to be discussed for the rest of the session. So thank you to them, and thank you for being here, and we'll take a break.